Okay, welcome back to our second session today. I'm now joined by my new co-chair, who's Dr. Naomi Hersey, who's one of our interventional radiologists in our MDT, who's a real part and core of one of our MDT teams. So I'm going to hand over to her to introduce our first speaker.
Thanks, Andy. Hi, everybody. So it's my pleasure to introduce our next speaker, who's Dr. Manu, who is a consultant gastroenterologist from the Freeman in Newcastle, who is a specialist in endoscopy management, particularly ERCP and EUS, who's going to speak to us about acute pancreatitis.
Thank you, Naomi, and thank you, Andy, for this very kind invitation to the Sheffield Symposium. As previous speakers have said, it would have been nice if we were there in person, but I'm sure it'll happen next year. And more importantly, I'm really pleased that we are now promoting pancreatology as a subspecialty in gastroenterology, and kudos to you and the team. So I've been tasked to talk about acute pancreatitis. Not something a gastroenterologist talks about much, but having been involved in the NICE guidelines and the endoscopic management, I thought it would be nice to share some of the guidelines and the data. So the topic is antibiotics and drainage. So acute pancreatitis in the UK, we get around 56 cases per 100,000 people per year. A quarter of these cases are severe and associated with complications such as cardiovascular, kidney, and respiratory complications, and development of peripancreatic fluid collections in severe pancreatitis. In more severe cases, people often need critical care and prolonged hospital stay with a mortality of up to 40%. For the purpose of this presentation, I thought it was important to highlight the different modalities of presentation of mild, moderately severe, and severe acute pancreatitis, which is based on the revised Atlanta criteria, because much of the presentation is focused on severe acute pancreatitis. So what is the role of antibiotics in severe acute pancreatitis? It is well established that infected pancreatic necrosis has a higher mortality and morbidity than non-infected necrotic pancreatitis. However, it is common for people with non-infective severe pancreatitis with necrosis to be given antimicrobial therapy with the intention to try and prevent development of pancreatic necrosis. And because of this practice, there have been some negative outcomes. So there are multi-drug resistant microorganisms, and subsequent infection is harder to treat because of the resistance patterns, leading to higher mortality. And this has been highlighted over the past couple of decades. So then where do we go from here? What is the evidence for antibiotics in severe pancreatitis? To highlight this, there have been quite a few studies done recently. The most important one was the one led by Derek O'Reilly from Manchester, the NCPOD report on the management of acute pancreatitis across the UK. And one of the things they highlighted was that 61% of the patients of acute pancreatitis received antibiotic therapy, and 20% were inappropriately prescribed. We have looked at our data at Newcastle through our remote care pancreatitis service, and 55% received inappropriate antimicrobial therapy. We extensively looked at all the literature surrounding this topic in the recent guidelines produced by NICE, and there is limited evidence of the clinical benefit of prophylactic antibiotic therapy, but also lack of clear evidence of harm. So it's neither here nor there, but the economic benefits are limited. So therefore, we concluded as a group that without strong evidence to support antibiotic prophylaxis, it would be inappropriate to go away from the principles of antimicrobial stewardship, which actually is tasked to ensure that the right patient gets the right antibiotic. So we concluded that do not offer prophylactic antimicrobials to patients with severe acute pancreatitis. So if there's one message that the delegates can take away from this particular talk is think very hard before you prescribe antimicrobial therapy, because there isn't evidence to support that it works, and you need sort of strong evidence through cultures from various parts of the anatomy to ensure that antibiotics are useful. So the second part of my talk is the management of pancreatic fluid correction or drainage. Before we embark on how we approach these patients, again, as per the revised Atlanta criteria, it's divided into two timelines. So less than 4 weeks and more than 4 weeks. And these timelines are important. And I'll come to it later on. So less than 4 weeks, you can develop sort of peripancreatic fluid collections without a defined wall. And majority of these patients actually get better. In the same time scale, you can develop you have patients who develop peripancreatic collections with necrosis within it. And this is unfortunate, happens in a small group of patients, but necrosis can actually develop in less than 4 weeks. These patients, by and large, do not get better on their own, or the peripancreatic fluid collections don't get better on their own, and it's sometimes better to watch and wait if it is clinically appropriate. But what happens after 4 weeks is what we see in our day-to-day practice. So you develop pseudocysts, so lots of peripancreatic fluid collections. And one of the most common scenarios that we see is a walled-off collections. These are different pictures, CT and MR, of walled-off collections, which have got a defined wall with gas and necrosis within it. These patients, by and large, do not get better on their own unless the collection is actually drained. So how do we approach these patients? How do we drain them? So there have been peripancreatic fluid collections have always been managed and have been on the remit of our surgical colleagues over the years. And therefore, the treatment options remained surgical approach. So you can actually get into the pseudocyst and create a surgical cyst gastrostomy. If you have a necrotic cavity, then you could use a laparoscopic approach, which was widely used and is also still used in some parts of the UK and Europe. But what has seen a sea change is the introduction of endoscopic intervention in the management of pancreatic fluid collections. So this is a case, I haven't got any videos because sometimes on webinars, videos can get stuck, but this is a case we manage with endoscopic necrosectomy during the management of this patient in ITU. The other option still remains percutaneous. So not all patients can be managed endoscopically. We need the percutaneous option. And this is a combination of radiology and then the surgical procedure. But one has to remember, these three options require radiological input, surgical time, or surgeon's time, theatre time, while the endoscopic option can be done in the unit. And with the newer stents that have been introduced, you do not even need X-ray, and these patients can be managed remotely in areas such as intensive care unit and the high dependency unit. So what did we recommend reviewing all the available guidance or all the available evidence in the NICE guidelines? So first, offer people with acute pancreatitis an endoscopic approach for management of infected and suspected infected pancreatic necrosis when anatomically possible. If not possible, then use the percutaneous approach. And in very rare circumstances, you might need to use surgical approach. But when deciding on how to manage infected pancreatic necrosis, balance the need to debride promptly against the advantage of delaying intervention. So this comes back to the slides that I showed on acute necrotic collection or even a pseudocyst and wall-off necrosis. If the patient is relatively well, do not intervene because you may cause more harm than good. So the timing, again, through the guidance, we have recommended that endoscopic ultrasound guided drainage for patients with symptomatic pseudocyst will be only based on when the patient actually have symptoms, so pain, vomiting, or weight loss. If the patient is not symptomatic, then you have to look for evidence of pancreatic duct disruption. There's some concern there's pressure over the larger vessels, or there's risk of rupture and suspicion of infection. So you've got to get in before the infection starts developing in the pseudocyst, and only consider surgical drainage if endoscopic therapy is unsuitable or has failed. But this is a slide which is actually quite important, because we talked about timing, how long should we wait, and how do we decide the time scale of or the actual time of intervention. So if you have a complicated patient with severe acute pancreatitis with a walled-off necrosis or pseudocyst, we would certainly recommend, and this is our practice, to seek advice. You don't have to transfer the patient to the specialist pancreatic center, but seek advice within the referral network. And sometimes it is not as simple as draining the pseudocyst. The patient may have pancreatic ascites, pancreatic pleural effusion, and that requires much more specific treatment. And you should discuss with the referral unit whether to move the patient to the specialist center for treatment of other complications. In terms of endoscopic drainage, I think, as I have highlighted, it is the modality of choice across most units in the UK. I know there are certain units in the UK who still prefer the percutaneous approach, and I don't think there is anything wrong with that, but just to bear in mind, there are a few long-term consequences of percutaneous drainage. So if you divide it into two categories, the pseudocyst, which is the clear fluid-filled cavity, and compare it with the necrotic cavity. So for the pseudocyst, I think the traditional modality of drainage has been the introduction of plastic stents. And I think Brain in Birmingham is very passionate about it. But what happened over the last 5 to 10 years, maybe, metal stents started coming into the management of this condition, including fully covered stents and the lumen opposing stents. But as time has gone on, I think people have realized, and as Gavin highlighted, if there is duct disruption on the MR or on other forms of cross-sectional imaging, and it is a pseudocyst, it is better to go ahead with the plastic stents because you can leave it for longer. There have been a number of case reports which suggest that metal stents can have tissue overgrowth, and an irremovable metal stent is not a very pleasant sight. But for necrotic collections, you need to go into the cavity. You need to do necrosectomy, and I think it is very well established that lumen opposing metal stents are better than plastic stents. And you can see from the evidence out there, it is slowly accumulating over the last 5 to 10 years. Now, one of the other things Andy asked me to present is our national study on the non-infective complications of lumen opposing metal stents in the management of pancreatic fluid collections. And the reason I decided to do this particular study was that, and the stent that we are focusing on is a hot axia stent by Boston Scientific, that there was an increased usage of this stent. And in spite of favorable results in literature, it was very important for us to ensure that we are doing the right thing. So we are very grateful to all the participants in the audience from the 18 NHS trusts who actually participated in the study. I do not have time to go through all the results, but I'll quickly go through the conclusions. So this is and continues to be the largest multicenter cohort study in literature of the use of LAMS of more than 1,000 patients. We had an immediate complication rate which included stent mile deployment, infection, bleeding, and perforation of around 3.5%, which is what is mentioned in literature. But the long-term complications were high, and majority of them were actually related to stent migration. Thankfully, nearly half of the migration was inside the stomach lumen rather than inside the cyst. But then some of them went on to have other complications. There was increased risk of complications if during the index procedure you did balloon dilatation and conscious sedation was used, but it just about reached the statistical significance. But what was more worrying was around 35 patients, not 35, so around 67 patients had tissue overgrowth over the lumen opposing metal stent. We were able to remove majority of them, but as we're using this more and more, we're going to see this problem developing over a period of time. So there's a word of caution. Yes, these are fantastic stents, can be inserted without X-ray, within a couple of minutes, anywhere in the hospital, but just take a step back to see if that is the right thing for the patient, or you can use another equipment. So to conclude, Chairman, ladies and gentlemen, prophylactic antibiotics are not indicated in acute pancreatitis unless there is evidence of infection. However, it continues to be a major problem across the UK in terms of prescription. Endoscopic approach is the treatment of choice for drainage of pancreatic fluid collections. However, the timing of drainage is crucial and therefore must be discussed with the regional pancreatic center. Neo-lumen opposing metal stents seems to be the treatment of choice for necrotic collections, but there is emerging evidence after a period of use of metal stent, that plastic stents may be as good as metal stents for the management of pseudocysts. I would like to end the talk to invite the audience to this very specialized webinar on COVID-19 and acute pancreatitis, where we will be sharing our results of the international multicenter study on COVID-19 and acute pancreatitis. Thank you very much.
Thanks for that, Manu. That was a really fabulous talk, and I think certainly as a radiologist, we here in Sheffield very much advocate the MDT approach, and I think just getting all groups involved and looking at all the options is certainly key to getting the best outcome for patients, and trying to individualise based on, as you say, anatomy, and trying to choose whether endoscopic or percutaneous or even possibly surgical options are the best way forward. There's a couple of questions from the audience, if I may. There's with regards to antibiotic use, there's questions as to whether you would consider antibiotic use in immunocompromised patients, or if you would consider antibiotics in certain scenarios based on imaging finding. For example, if you see gas within a collection, would you then consider using antibiotics?
That's a very good question. The answer to the first half of the question of immunocompromised, we actually looked into this during the NICE guidelines. This was specifically asked by one of the members. And again, there is no evidence around it. But like with other forms of sepsis, it's very important we try and get a feel of which organism we are dealing with, because increasingly there is a tendency to give blanket antibiotic cover. So for example, if you've got gas in the collection, if the patient is septic based on the biochemistry results, so for example, CRP and the white cell count is high, what it suggests is there could be gas-forming organisms, but this could still be a sterile necrosis. And what needs to happen is that you need to drain the collection rather than treat it with antibiotics. And usually draining the collection, either endoscopic or percutaneous, usually sorts the problem out. Secondly, during the time of the drainage, you can collect some fluid and send it off for culture. And then you will get a better idea as to what you're dealing with. The second half was about, sorry, can you remind me again, Naomi, what's the second question?
You to want to use antibiotics, but I think you sort of covered that really, that it's not really imaging findings to want to do to introduce antibiotics. It's more about using that to guide drainage.
Correct. Yeah. That is the practice we follow in the Northeast, because all cases of severe acute pancreatitis are referred to our unit. We discuss it. We have exactly the same discussion. Oh, there's gas in the collection, but gas in the collection suggests yes, there might be something grumbling. It could be fistulation into one of the other cavities in the stomach. So draining the cavity is more important than rushing in with antibiotics.
Manu, thank you for the data. The UK data is fantastic you've developed. There's a number of questions and points about the Axius stents that are being used. Do you think we're leaving them in too long? 1% overgrowth rates, interesting data. Should we be bringing these back out? Is COVID been caused a problem, do you think, or when do you take your stents out?
So I think the accepted time of removal, as you know, Andy, in literature is 4 weeks. And what we have looked in our data, I haven't been able to present the whole thing, the median time of removal in our data was 7 weeks. We tried to look at whether removal at 4 weeks, 6 weeks, 8 weeks, and 12 weeks made a difference, or whether there was more complications, i.e. tissue overgrowth, and there wasn't. So what this data highlights is what, sometimes you go by what is there in literature, but when you start looking at your own data, you start thinking, well, is 4 weeks the right time? Is 6 weeks enough? 4 weeks, I think, is probably enough if you're using it for pseudocysts. But if you've got a necrotic collection, which needs lots of necrosectomy, as you know, you may have to sometimes leave it a little bit longer. But again, we still do not have a definite answer for that. But from our study, it was 7 weeks. Tissue overgrowth is continuing to be a problem, and I think more and more people are going to be seeing that in the future. And sorry, the COVID situation, yeah, I mean, the COVID situation has made things worse. Initially, for the necrotic cavities, we used to rely on our surgical colleagues and ITU colleagues to tell us when the patient's better, and then we go ahead and remove the stent. But now we have made a conscious choice in Newcastle that as soon as we put the stent in, we book the repeat procedure for stent removal in 4 to 6 weeks so that the patient doesn't get lost to follow-up. And if it comes to 6 weeks and the patient's still in ITU, then maybe we have to consider take the stent out, put a couple of plastic stents in, and continue with the necrosectomy.
Thank you so much for your time today. It was a fantastic talk, as we expected and hoped for, and wish you all your best for your meeting on March the 23rd, I think you said it was. So, another